Welcome. I'm Madeline Jacobs, MD. I'm on the board of the Colorado Foundation for Universal Healthcare and chair the medical professionals for Universal Healthcare under its auspices. We are recording this so folks can view at a later date, and we're live on Facebook. We'll have our panel do some introductory remarks and then open up to questions. You're muted, but we would love to hear from you. So if you can put your questions and comments into the chat, we would appreciate that. This is the fourth in a series of shattered events highlighting how healthcare touches on all aspects of social well-being and how the current system does not meet those needs. Today's topic highlights three aspects of healthcare, which, unlike the current system, have the same goal: maximizing the well-being of all people. Thank you so much to our panel. Mark Wallace, who will speak about public health, Mitzi Moran, who will speak on community health, and Bernie Birnbaum, who will speak about primary care. First, I'd like to introduce Dr. Wallace. Mark Wallace, MD, MPH, is the Chief Clinical Officer for Sunrise Community Health in Northern Colorado. He has served as the Healthcare Officer and Executive Director of the Weld County Department of Public Health and Environment for over 2 decades. He has held many other positions and has received many honors. Thank you for being here, Dr. Wallace.
Well,
you're on.
Great. Thank you so much for the opportunity to join you all. I look forward to talking about one of these key elements of a system, and that is public health. So I started off with really talking here in general about promoting, protecting, and maintaining the health of communities. And as you heard, I started off as a primary care clinician, and remember back in those early days when I was training as a medical student and going through my primary care family medicine residency program, trying to get engaged with this movement that was going to talk about having a universal system and battling whether or not that was a right. Many of us thought and continue to think that it is. And I remember as a student being a little bit discouraged in those years, those early years. And so my journey to sort of wanting to really emphasize here public health has been one in which working in that primary care side, looking at the kind of individual care that gets delivered, and recognizing that I felt that I was missing some of the tools that I needed in order for us to really make a difference in a system that would focus on maximizing health for everyone. And so spent my time walking in both sides, in primary care and community health, and then over in the public health world. And so really the way we do some of this work today is by collaborating across the care continuum and out into the community. If we go to the next slide, I want to kind of come into public health. This is a wheel that many people who are familiar with public health and the way it's organized in the United States is around these 10 essential public health services. So there are 3 main areas of work that look at assessment, assurance, and policy development. And while not every health department, they're quite variable. We don't have a standard way of delivering public health in this country. In Colorado, public health is very decentralized at the county and in some cases regional level. And there is a connection between the state Department of Public Health and Environment and those local departments of public health. But it's not as coordinated at times, nor does it ensure that all agencies deliver these same set of services. So I don't want to spend time going into the details beyond the fact that these are critical areas when you look at a health system, is assessment. We've got to understand the people and the populations and communities that we're serving. We have to look at and investigate trends that may be going on, new diseases that may be emerging, diseases and conditions that may be becoming contributors in large numbers to early morbidity and mortality. We also look at this side about assurance to be certain that we've got the infrastructure, that we've got ways that we're looking at the workforce and equitable access and assuring that we're achieving that system that we're hopeful for. And then obviously, folks tend to be familiar with some of the policy development that goes on inside this segment of a healthcare system about how do we educate individuals, how do we look at strengthening and supporting communities and those partnerships that exist, and then how do we look at where it is important to use either policy, laws, or regulatory actions to help us achieve the opportunity for everyone to not only achieve health, but to thrive. And so I just gave some examples here about public health, has been critical really when you look at what has increased life expectancy over the years and contributes to decreasing infant and child mortality. There's some examples over here. Obviously having clean air and clean water have been very important. Being able to treat and prevent the spread of infectious and communicable diseases are some of the foundational elements that if a system doesn't have those built in, you're starting behind, and you're not going to be able to have the right conditions to actually assure that you're starting at a place where folks could avoid conditions or diseases. Some of the other more specific things, car safety, where we have seat belts and we have standards for putting children and infants into protective seats. Looking at tobacco and other substances as health hazards, and looking at ways through a combination of education, through policy, things like clean indoor air, that we get at these factors that take away the opportunity to be disease-free and to thrive. So just gave some examples of where some of these are policies, some of these are direct services, some of these are in the area of assurance when you're doing water testing and having safety standards for water. So this background and foundational work often grows out of our public health system. So if we go on to the next slide, it's just a different presentation. I really view public health as being one of those fundamental building blocks that assures the conditions in which people can be healthy. And so as you come through that, I've mentioned a lot of these already, looking at clean air, including clean indoor air, clean water, looking at safety standards, whether those are occupational standards that apply to work sites, whether those are safety standards around seat belts and the way car safety is designed, looking at things all the way over to school nutrition programs, obviously preventing the spread of disease and the development of it through vaccinations or reportable conditions, understanding the risks that are in community and how to avoid those and reduce those. So a variety of things. I didn't want to miss the one here, that one of the really fundamental parts of the healthcare system has to be to collect, analyze, and report on information about our communities. So about the individuals, about the community at population levels, and in various ways, so that we understand what exists in our communities, where there are inequities, and then how do we address those as we move through this continuum of care. So on the next slide, I just wanted to jump in. One of the things that I think we get caught up in as we try and look at public health, community health, primary care, are sort of what do we mean when we talk about health? There's lots of references that come out. I've given some examples of some health domains that are fairly common to individuals, and our systems being built around the delivery of physical health care, behavioral health care, recognizing other factors and other types of health domains. But also then when we get into what are we aware of, how are we taking a look at the conditions that exist for health or the status of disease, there can be measures that we use, either a single point in time. Are we trending that over time? Are we measuring a return to wellness after a sort of journey into dishealth? And then, even sometimes we have to look at just what's the best possible degree of wellness once chronic disease has established itself. And then the gears in the center are sort of, these other domains that influence our ability to achieve what we're hopeful for, which is a healthy population that is thriving. And so educational status, income status, genetics, behavioral choices, where we live, all of those other conditions that then impact what do we mean when we're talking about health. It's a very complex phenomenon. And so we can come at this in many different ways. On the next slide, I just wanted to give an example. Often when we talk about public health, we're frequently talking about the health of the complete population, a little bit different than population health management, which is often what when we slide over into providing clinical care, we tend to talk about managing populations that are actually subpopulations. So it might be that on the public health side, those foundational elements, we are really talking about a population, some of which is engaged in care, and other segments are perhaps not involved in clinical care, but are still of interest to us when we're looking at the health of our communities, our state, and our nation. And so looking even within that total population, getting down and saying, well, wait a minute, what's going on in the 80634 zip code of Greeley? What about populations of color that some are in care, some may live in the 80634, some might not be engaged in care, might live in other areas. And so how do we look at these populations that are not only engaged in clinical care? When you go over then to the right side, we're really talking about the way we look at it from a clinical service delivery. Who has diabetes, who has hypertension, who has cardiovascular disease, who has COPD. These are often individuals that are under our care. They may have multiple conditions, and so we look at that and want to manage this as best we can as a system. First, to try and prevent those, but once they are conditions that have presented themselves, how do we get the best outcome that we can? And then what are the ways that we're trying to intervene, looking at socioeconomic disparities? Many of these things have to be delivered outside an exam room, outside a surgical suite. But we are also looking, when we want to manage populations in our system, we've got to be looking at technology, processes, and what can we do proactively to improve the likelihood of our populations being able to maintain wellness. If we go on to the next one, I don't want to leave out that one of the things that we really have to be focusing on, and often these are places in which the public health and part of our system will look at what are the influences and what are the interventions that can be done for these other determinants that are not directly related to the provision of healthcare services. So looking at things like economic stability, looking at food access, looking at what's the safety of a community, what are those stress levels, what's the trauma levels inside our neighborhoods, in our families, in our communities, and then looking at ways in which we would collectively come in and have those elements not be left out of the solution as we try and assure the best conditions for every individual to be healthy and thrive. And so I put those in because often these are places in which different parts of our system, as they're organized today, come in. Some of these are delivered through community health, some are delivered through traditional primary care, if it's a component that they can reach. But without these being considered holistically, we leave the care delivery system with an unreasonable expectation that it alone is going to be able to ensure the conditions exist for folks to be healthy and to fully mitigate the influences that prevent folks from achieving that outcome. And then the last slide is just really this sort of continuum of care. It's just an example of where, while it's labeled personal health, often on the prevention side, that's where we see our public health system come in, looking at those various factors that exist in community. And then moving through this, but hopefully coming back through, if you do end up with conditions or diseases, that we can collectively then get folks back to enjoying good health, wellness, and the opportunity to thrive. So I will stop there. I just feel that this is one of the foundational elements of any universal system, is to ensure that we have successful and sustainable public health. We recognize they are underfunded. The pandemic has taken a huge toll on the professionals and the ability to deliver these core services. And so it can't be left out, in my opinion, when we're trying to talk about what does a universal system look like. So thank you for the opportunity, and I will end there.
Thank you, Mark. I'm having a little bit of internet trouble, so I'm turning my video off. But moving along, our next speaker is Mitzi Moran. Mitzi was raised as a fourth generation on a family farm in Yuma, Colorado. She is the CEO of Sunrise Community Health. She was chair of the Healthcare Cost Savings Task Force, and she has a storied education and experience in community health. She is passionate about Sunrise's mission of, quote, affordable access to quality care for all, close quote. Thank you, Mitzi.
All right. Thank you, Maddie. So I have a few slides to walk through what is community health, what is a community health center. I'll start first by saying this is Sunrise's 50th anniversary. We started in 1973, and it's my 25th anniversary at Sunrise. So for me, it's a big year, right? So let's start with community health centers. They began in 1965 with President Johnson's War on Poverty. And the concept was, let's take federal dollars and put them at the local level and let local people decide what are the challenges and what are the solutions. And you're going to hear that theme as we move through these slides. Let's go to the next one. So today there's over 1,400 community health centers across the US serving over 30 million people. We are a big part of the healthcare system. However, we are a targeted part of the healthcare system. You can see the insurance and poverty reflected there in the stats, 55 billion in economic activity. So that's salaries and benefits and building buildings and X-ray and IT and all that kind of thing. Interesting stat there is 24 billion is saved. When you compare a Medicaid or a low-income Medicare patient served at a community health center compared to being served elsewhere, that's the kind of savings you get. And it is a result of our culturally competent care and our team-based care. You will hear more about that in the slides. You can see the numbers for Colorado. To be an FQHC, there are over 200 elements you have to comply with, 19 core requirements. We don't have time for all that, but I am going to show I want to talk about 4 core pillars to be in a community health center. Let's go to the next slide. First one is community-directed healthcare organization. So 51% of our board must be patients that we serve. So we do patient satisfaction surveys like everybody. We do patient focus groups where we pull patients in and say, hey, help us think about our pharmacy flow. But we also have the patients as the majority voice on our board of directors, deciding hours of operation, deciding what services, if we have a profit, how to use that. They hire and fire and evaluate the CEO. They have a real voice in governing the community health center. It is hands down one of my favorite things about being an FQHC. Second favorite thing, or very close to the first, is we serve everyone regardless of their ability to pay. Hi, I have Blue Cross Blue Shield. I'd like to make an appointment. Sure, we'll make you an appointment. Hi, I have no insurance. I'd like to make an appointment. Sure, we'll make you an appointment. Insurance doesn't open or close a gate at Sunrise. We don't actively market towards those who have insurance because there are resources for them. But we are actively looking for uninsured, underinsured. I have medical insurance, but I have a $10,000 deductible. I have medical, but I don't have dental. I have dental, but I don't have medical. That's our population. That's who we're trying to reach to serve. However, again, we turn no one away, regardless of whether they can or can't pay for their services. And I'll talk more about a tool we have that enables us to do that work. Let's go to the next slide. So a third core pillar is culturally competent, comprehensive primary healthcare. It is a mouthful. So in the blue box there, you can see what are required services at an FQHC: primary care and Based on community and patient need across the US, FQs add services. For us, we added additional dental services beyond the screening, the preventive dental that we're required to do. We've added behavioral health. We've added optometry, nutrition, complementary alternative medicine, podiatry, and psychiatry. But we didn't stop there. We also have added educational type services, because it's incredibly important in our mind that someone's health is defined beyond medical, dental, and behavioral health. It's also their socioeconomic health. It's also their literacy health, their educational health. So we have a strong Reach Out and Read literacy program. We have Women, Infant, and Children's, which is focused on nutrition and health education. And just recently, the Immigrant and Refugee Center of Northern Colorado joined the Sunrise family. You can see over on the right, I've got that three-legged stool there. We think of FQ services of being medical, dental, and behavioral health. And if any leg on that stool is short or wobbly, shorter, skinnier, the stool's wobbly. We don't want that. Then we have this whole wraparound set of services that you can see in those boxes. But just think about it. If I'm a diabetic patient and my mouth is not well, I am not likely to be able to eat the nutritional foods that I need to eat in order to manage my chronic disease. If I have a chronic disease, I may have anxiety, I may have depression, I most likely have behavior changes for me and my whole family that are needed. So putting medical, dental, and behavioral health together and all the wraparound services create a healthcare home for our patients. Speaking of the healthcare home for our patients, up in the upper right, if you can see that picture there, it is one of my all-time favorite pictures, and it represents the heart of Sunrise and many of the FQs across the US. When COVID hit, we knew that we had to be the healthcare home for our patients. 42,000 people is who we serve a year. They needed access to affordable care. They needed access to COVID respiratory care. So we leaned in really hard, and we made all of our decisions in COVID balanced against three things. Are we standing steady for our patients? Are we standing steady for our partners? And are we standing steady for our people? So how do we stand steady for our patients? The first month COVID hit, we immediately redesigned flow, screened at the door. If you have respiratory, you go this way. If you don't have respiratory symptoms, you go this way. Never shall the two meet, because we had to be there for the COVID needs. But hypertension and diabetes and babies didn't go away during COVID. That care was still needed. So we had to redesign our flow. We condensed our clinics to bring all of our staff in to where the most traffic was happening in our larger clinics. We had to stand up telehealth. We had to stand up, we had never done that before. We stood up pharmacy grab and go, pull up, text us, we'll run your meds out. That way you don't have to come in the building. We knew we had to be there for our patients. And that picture is a great example. Notice it's a handwritten sign. It's on a handmade pole. We've got Dr. K leaning on the sign. He's one of our pediatricians, team members out there, the snow in the background. Okay, we're going to deliver care outside today because that's what the new rules are. We can adapt. We can be nimble. No, actually, next week we're going to have to do it inside. No, we're going to have to condense. No, I mean, it was just chaotic, but the team did it. And as a result, we ended up being one of the leading providers of outpatient COVID care. So we stood steady for our patients, and we were the leading vaccinator in Weld County. And I'm particularly proud of that stat because almost 50% of the people that we vaccinated identify as people of color. Affordable access, quality care for all. And over 37% were not Sunrise patients. So we really did serve the whole community. We stood steady for patients. By doing that, though, we also stood steady for our partners. Because if we would have backed up during COVID, where would our 42,000 patients have gone? They would have gone to the hospitals, and they were overwhelmed. So we stood steady for partners. We stood steady for our people too. Making sure that they were supported, that they had time off, that they had additional income, that their salaries were addressed, that there were bonuses, everything that we could do to help them, because they needed to be supported because they were doing the work caring. So again, standing steady for our patients, our partners, and our people. It was absolutely exhausting, and it was also exhilarating, right? I just cannot tell you how proud I am of this team. Let's go to the next slide. Third core pillar of a community health center is we must be located in high need areas. So that map there, upper left corner, is Fort Collins down to Berthoud, over to the right in Kersey, Fort Morgan area, and up towards Briggsdale and Alp. The darker the color, the more people that live at 200% of the federal poverty level or less. And that's the indicator that they need access to our services. But what I want you to notice is that there is hardly anywhere where there is no color. So people sometimes believe that FQ patients live in pockets. And while that's true by intensity, the need is throughout our entire community. Look at the stats on this slide. Over on the left, 25% of people in Larimer County live at 200% of the federal poverty level, 1 in 4 in Loveland. But of all adults, regardless of economic background, 20% didn't go to the doctor over the last 2 years because they felt it was unaffordable. Look at the Weld stats on the right-hand side. 40% in Greeley live at 200% of the federal poverty level, and 30% of adults said they went without needed care due to cost. I have a picture down there on the bottom right. It's a picture of our Windsor Clinic. Now, Windsor is sort of known as the Cherry Creek of Northern Colorado. and people were a little bit surprised that we chose to open a clinic last August there. But we announced the clinic. It's a one provider clinic right now. We announced the clinic on a Friday. We opened on Monday, and we saw 60 people that first week. 3 weeks later, we had a woman who walked in. She was 5 months pregnant, and she said, "I am so glad you are here. I have no transportation. I have had no prenatal care." Well, as a CEO at Sunrise, I didn't need any more validation that we made a right choice to open up in Windsor. Because even though Windsor has maybe a higher average income, there are lots of services being built in Windsor, and a lot of our people work in the service industry. So their need is there. You can see that blue box. We do have, I think on my next slide, oh no, I don't have it. We have 12 clinics in Evans, Loveland, and Greeley. We serve the greater Larimer and Weld community, 400 employees. 60 of them are physicians, advanced practice providers, dentists, hygienists, or pharmacists. All right, let's go to almost my last slide. So let's talk about our patients. Just under 41,000 patients last year, 90% lived at 200% of the federal poverty level. And that is the limit to which we can offer our federal sliding fee scale. So one of the ways we are funded is about 14% of our budget is we get a grant that helps us offer a sliding fee scale to patients. Based on their family size and based on their income, we can take a $500 bill and potentially drop it to $10 or $20 or $25 or $60, just depending on that family size. And that grant is what helps us do that. It's what lets us offer affordable access to quality care to all and turn no one away based on their ability to pay. However, 53% of our patients have Medicaid. 25% are completely uninsured. That number is very different than when I started at Sunrise. It was flipped. When I started in 1998, clear up until till about 2008, it was 50% uninsured and 25% Medicaid. And part of why that happened is think about our healthcare system historically. If you lived with low income, you may be qualified for Medicaid. If you were 65, you had Medicare, right? And in between there, you hoped you had a job that provided health insurance. You hoped that health insurance didn't have a lifetime limit in case you had someone very ill in your family. You hoped that if you moved jobs, there wasn't going to be a pre-existing condition that you were faced with, right? Then in 2008, Colorado, it was a bipartisan decision, chose to expand eligibility for Medicaid. So they moved that up a little bit. Then the Affordable Care Act happened and we expanded Medicaid to match it. So that's great. The Affordable Care Act also offers subsidies, taxpayer funded subsidies for people up to 400% of the federal poverty level. All right, we inched it a little further. That's great. There is still a chunk in here though, that the challenge of affordable healthcare is not over. For instance, for Sunrise, our family insurance program, our premium is $30,000 a year. Who can afford that on the open market? Now it's a platinum plan. It is very nice, but who can afford that? So whenever I meet with legislators, I always tell this story and ask them to not throw the baby out with the bathwater. Don't get rid of Affordable Care Act type improvements, but keep working. We are not done, right? This is where I think it's a good place to talk about why community health and public health are a little bit different. You saw Mark's slide, you saw the broader scope. Sunrise is very much focused on many of those things in his slides, but we are targeting low income, uninsured, underinsured. So that's a difference. We're not targeting the entire population. We're targeting a certain portion of the population. Over on the right, you can see more stats about our community health center, what we do, the seasonal migrant farm workers. It's been a program of ours since the beginning. 46% of our patients are, English is not their primary language. However, doesn't mean they don't speak English. It's just not their primary language. Let's see, anything else I want to highlight on here? Nope, I think I'll stop there. Let's go to the last slide. That's my ending slide. I'll point out the picture on the left. That is Dr. Wallace in the front, Chief Clinical Officer at Sunrise, and Dr. Colgrath in the back, who's our Chief Dental Officer. I just happened to snap the picture when they're both ready for the next COVID vaccine person. They help serve in our mass vaccine clinics where we could do 1,200 a day. And I just love that picture that they are standing ready to serve. So I will end there and let Bernie go.
Thank you so much, Mitzi. Next is Dr. Birnbaum. Bernie Birnbaum, MD, is a family physician and associate program director of the UC Health Fort Collins Family Medicine Residency Program and has practiced in many underserved communities. He also currently serves on the Board of Health for the Health Department of Larimer County. You're on.
Nice, awesome. Hey guys. I think that this actually works really well. I'm kind of seeing how this funnels down, right? I mean, we described the public health system, and I'm going to tell you why our public health system in the United States is drastically underfunded. We described a system of care for the underserved, and now we're going to talk about individual care and how primary care and public health can interact, and need a lot more to actually be successful in what we do. Can we go to the next slide? We spend more money per capita than any other country, but what do we spend it on? I think we spend our funds on the high-tech, high-cost technological provision of healthcare, and we focus that on individuals, not on the community. According to the Robert Graham Center, less than 3% of our healthcare spending is on public health. Only 5 to 7% of our healthcare dollar is spent on primary care. That's about half of what countries that have universal access or single payer systems spend on primary care, and drastically less on public health. There is a clear utilization between primary care spending and ED utilization and overall spending. Next slide. So what is primary care? I think Dr. Wallace did a great job of defining what public health is, but primary care is the provision of integrated accessible healthcare services by physicians, and this is the definition from the American Academy of Family Physicians, and their healthcare teams, accountable to addressing majority of personal health needs, and developing a sustainable partnership with patients practicing in the context of family and community. Notice again, the focus is on the individual coming to care in a community aligned way. I think that's a vital thing to understand. And I think that this is something that people don't understand when they think about the definition of public health, the difference between public health and primary care, is that public health is concerned with the wellness and well-being of the entire community. And that doesn't mean that it won't get into individual health when that individual health affects the community. My job and the job of your family physician or your general internist is to focus on person-centered care. And in order to do that well, in order to do that in the context of community, we need information that helps us do that. In the United States, less than 30% of physicians are in primary care. In Canada, it's nearly 50%. Next slide. Despite spending nearly double what other industrialized countries spend on healthcare, and I'm sure all of you guys have seen this information before, we have outcomes that are drastically worse in many areas. And examples of that are life expectancy, infant mortality, maternal outcomes, obesity, and chronic disease burden. In fact, during the pandemic worldwide, there was a decrease in life expectancy. That decrease has continued in the United States and improved in many other industrialized countries or developed countries. Family physicians need to understand, and primary care docs need to understand the social determinants of health. But how, in the context of the system in which we work, can an individual practicing physician affect those social determinants without partnership with the public health world, and without partnership with the public health world that's been given the tools to deal with that? We do have a critical role in pushing the integration of public health and population health level data that will influence policy. I think one of the things that Dr. Wallace did a really nice job was separating the idea of population-based health to drive my practice as a physician versus public health data to push policy. And those things really need to be differentiated. My organization is certainly looking at data to help us inform how well are we doing with preventive health maintenance guidelines, or how well are we doing with chronic disease management. But realistically, that again is mostly affecting the individuals that we serve, not on the community level. Next slide. This is really a repetition of a slide that Mark put on a little while ago, but I think it's really important. Again, the health system is all the way over here to the right in disease and injury. All of these other things are actually what's affecting the health of the population. Why are we focusing our dollar so much on disease, injury, chronic disease management, when in reality, we're not spending the time to focus on social inequities, institutional inequities, living conditions, risk behaviors that bring people to me in the first place? I think we need a restructuring of how we think about that. Next slide. This slide was another slide that I found that sort of, I think, outlines this again really well. There is clear overlap between primary care and the population health or the public health data system. But those things are not the same. And unfortunately, I think in the general populace, they're often put together. Where we work together is on a lot of the wellness stuff. And the data that public health brings informs the practice of primary care if the system is organized around it. And I think where the community health center fits into this really well is the community health center is a response to public health data. It's a response to inequities, a response to the lack of access for a large percentage of our population that is driven by the data and by the influence of public health. Next slide. So what happens in other countries? The US has a limited primary care workforce compared to countries with single payer universal access systems. US citizens have less visits with their personal physicians and are more likely to seek care in urgent care and emergency rooms. This is expensive. For our poor outcomes, we spend 17% of our GDP. Switzerland, which in Europe spends a lot of money, spends 12%. Imagine what we could do with 5% of our GDP. Imagine if we could put 5% of our GDP into the social determinants of health or into education. You as adults are the least likely of industrialized countries to have a regular primary physician, and even less likely to have a continuity relationship. And this was a statistic that I loved, which is in the United States compared to other countries, there's a very low rate of home visits. And the way that I translate that is that we've structured our system to ask people to come to us. And while that may be efficient, it may not be effective. Next slide. So medical organizations must push our society to actually invest in public health infrastructure, because if we don't address the social determinants of health, we can't allow our population to thrive, which again is the goal of the medical system and of primary care physicians, and the goal of public health is the same, and that's a thriving population. We're just focusing at different levels. We must invest in infrastructure, the primary care infrastructure, but this alone will not improve the health of the public. We can have lots and lots of primary care doctors, and we can put money into primary care, but without that being informed statistically, we're not going to be successful. I think actually a great example of that is Fort Collins. We have tons of primary care doctors in Fort Collins. We really do, but not for people who have Medicaid, but not for people who are struggling with inequities. And I think that that's a real key thing. I think you can look at different communities and say, we're doing a great job. And I think one of the slides that Mitzi Moran showed that there's need everywhere, but we're not addressing that need. And the community health system was one that's an attempt to do that, but it's insufficient. In order to stem the tide of excessive healthcare spending, we must simplify our system and focus on what actually improves wellness, lives, and morbidity, rather than focusing our spending at the end of the line. And public health data will inform that process. Other countries have figured it out. We don't need to reinvent the wheel. And I think that we can look to our partners around the world and say, what elements of their system really work best? I think I'll leave it at there. Next slide. Yeah, that's what I got.
Thank you, Bernie. Yeah, just so people know, we're going to have questions at the end of this. If you have questions, put them into the chat, and Bill and Elaine will be bringing them forward for us. Before we go on, we want to let you know what you can be doing to help. Many of you on this call already know about House Bill 23-1209, which is at the top of the list. It just got out of the House and is going to the Senate. So there's a lot you can be doing. All of this information is available on our website, which is also on there. So please join us in making this a reality. And of course, for everyone who, one of our actions is to donate, obviously, because we are definitely a very underfunded movement. So, okay. So we'll go ahead and open it up to questions for our panel. And Bill, have you got any questions for us?
Yeah, a few things. And one thing we'd just like to mention is that, well, first question would be for the panelists, the slides that you presented were wonderful. Are you okay with us forwarding those slides to the people who've joined us this evening?
Absolutely. I
Yes.
will say that I did not submit a formal bibliography.
I didn't submit a bibliography either, but yes.
Okay, that'd be great. And plus this page that's up on the screen now that has all that information, we can send that out with it also, so you don't have to write all that down, and so you can just relax while we do this.
Thanks for that, Bill.
So one of the questions is probably for Mitzi. Is there a list or a way for people to find out what the federally qualified healthcare centers around the metro area are?
Yeah, if you go to Colorado Community Health Network, cchn.org, you can find a map of all the community health centers here in Colorado. If people wanted a broader perspective, they can go to the National Association of Community Health Centers, NAC, NACHC.org, and that would provide you a list of all across the nation.
Okay. And maybe another question would be, and I think we've been talking some around this, but is the fragmentation in our healthcare system, does that relate to the problems with longevity that we're seeing, the lowering of longevity in the United States? And would a more integrated system, how would that make a difference?
I mean, I can take a stab at that, and then we can see if anyone else has anything to add. Absolutely, the fragmentation of our healthcare system drastically affects outcomes, and there's particularly for those at the highest risk of bad outcomes. If we had a health system that was actually informed by putting the elements of care where they need to be, not where they're most appropriately paid for, or not where they're most profitable, I think we'd have a much better system of care. I think, at least speaking for Northern Colorado, we have a pretty well apportioned system of care, as long as you can pay for it. And the reality of it is that because of federal and state law, you can get high-tech care without the ability to care for it, but you may not be able to get the things that actually help you get stellar outcomes. So again, in Northern Colorado, it's a great place if you have trauma, you're going to get fantastic care. If you have heart disease, you're going to get fantastic care in that acute care setting. But what about the follow-up? And then the fragmentation between public health and primary care, between public health and the rest of the healthcare system, means that we don't always have adequate data to know what services are needed where. And again, I think the community health center system was a way to try to address that.
Yeah, and I think another example to sort of weigh in where there's a disconnect, we saw sort of unmasked with the pandemic, especially in the early stages. We were seeing in the beginning, for example, in our region even, young people who would not typically be admitted with severe respiratory illness, and especially not to the point of requiring intensive care and ventilation to be supported. And we began to recognize that this was potentially complicated by the work environment that these young people were in. And we did not have a system that was coordinated to say we could get in, and through prevention measures, as limited as we knew them to be at the time that COVID started, about social distancing, about masking and all those other things. We didn't have a way to quickly get in and create an environment in which could have been safer. Instead, what we were doing is saying, well, all we can do is put them in the intensive care unit, pay for them at that end, either through Medicaid, through some sort of charity-based care, or if they happened to be insured. But that again was sort of a total disconnect. I think we're going to have young people dying in an ICU over something that, if we had a system that could respond quickly with interventions that were preventive in nature, we could have avoided morbidity. We could have certainly avoided cost, but we were unable to do that. It was a challenge to get in, given our structure, to respond to a novel disease. Not novel, we'd run around in different forms, but how aggressively it came on this time. So, this whole public health prevention side, insurance health side, all that, I would start my days many mornings back then with calls from the chief medical officers of our health systems saying, what are we going to do? We can't keep having 20-year-olds, 22-year-olds, 27-year-olds admitted to our ICU and then die in a week. But we didn't have a solution quickly at hand.
So the only thing I would add to all of that I agree with is, here's an example of something we've done to try to defragmentize, if that's a word. We partnered with the local public health department because they see many of the same patients that we do. And we implemented implemented, manage the same electronic health record. So no matter where the patient goes at a Sunrise clinic or at a Weld County clinic, the full patient chart is available. So not only is that more cost effective because we're sharing the cost of one tool, it is also better care. My full list of allergies is wherever I go in those two systems. The fact that I just had 2 prescriptions given to me last week and one is an opioid, Dr. Wallace sees when I come to Sunrise. He also sees that I had an ultrasound ordered last week. He's not going to order another one. He actually probably can find the results and give them to me. So it lowers the cost of care for the organization, but it also lowered the cost of care for the patients. And that's a way we're trying to address how things can get fragmented. And truthfully, like mentioned, I'm from Yuma, Colorado. My family out there, my father particularly, sought care from UC Health, from Banner, in Yuma, Sterling, Fort Morgan, Fort Collins, Loveland, Greeley. And the number of times I had to retell his story and how many surgeries he had and how much medication he was on and where we were at in his cancer treatment, I ended up printing off a list that I just kept copies and would hand to people because their systems were not talking. Drove me insane.
I would love to comment on that real quick because there was a question in the chat specific to electronic health record portability. I mean, I can think within the patients that I serve that they're being exposed to 6 or 7 different EMRs, where some of that information is portable, some of that information is findable in those EHRs, and some of that isn't. And quite frankly, it's actually both dangerous and very, very, very expensive. Because if one patient has a hospitalization at hospital system X and they go to hospital system Y, studies will be repeated that don't need to be repeated. Now, part of that is because there may be a financial incentive to do so, and part of it is that we're all trying to cover our butts and do the right thing for the patient. So I think that one of the elements of a true unified system would be that we would all be documenting in similar ways. It's unfortunately parochial and it's unfortunately business, meaning that different organizations want to have their own control of their own information, and that inhibits quality care.
Thanks for that, Bernie. I just have a comment about that too, having had to deal with EHRs like you all have. Unfortunately, like the rest of our healthcare system, EHRs in this country are about profit, and it's not about healthcare. So in my experience of being an advocate for family members as well as having to deal with those, the purpose of those systems is to maximize billing, not about communicating information about what's going on with the patient. And, you know, so often when I had to take a family member to the emergency room or whatever, they couldn't even just enter what the medications were that my family member was on. They had to come to what they thought was the closest thing because that was not an option. It was checking off boxes, not actually entering the actual information. So EHR in this country is horrific. France, on the other hand, has a fantastic system where you carry your health record around on a card in your wallet, and wherever you go, if you give your card to the provider, they will have your entire medical record and can add what happened to you in that space. So it's available in the world, just not in this world.
Yeah, it is available. And there was also a question tied to, you know, can care be delivered at home? Yes, care can be delivered at home. And, you know, it's fascinating today that we're talking about hospital at home, you know, because hospitals are beginning to realize, and payers are beginning to realize, that there's a bunch of care that doesn't need to be delivered in the hospital, that it is actually safer and better at home. We are slow to the game. Other countries have been delivering care at home. It's not unusual. We mentioned France. There is this card, as we just heard about, but they also, what do we do when we go to somebody's home? We pull up in some big old vehicle that has lights on it and sirens, and we call it an ambulance. I travel to France quite a bit, and their teams, including clinicians, pull up in a little car. Pull up in a little car, pull into the alley, hop out of the car, run in and have a little bag. They don't have all, I mean, they're not coming with all the stuff we bring and all the cost associated with it, but they arrive in a car and they go in and they do that assessment, and that person can have things that are easily done, you know, carrying some IV solution if they're dehydrated and you need to give them a little bit of fluid. And it's just remarkable to see. And I get so jealous all the time because I think back to my early days when I was in geriatric medicine. And my goal was to really take care of folks as they aged, so that they could remain in their homes and communities, and including dying at home, which was, you know, this phenomenon that's so bizarre. A lot of us used to die at home, and then we change it all, and you got to go die in the hospital. There's lots of things that can be done to deliver care at home. Lots of things.
I think that there are still a lot of primary care docs that do home visits. Myself, a lot of our partners, there was someone else in the chat. The problem is we're not funded to do so. And the structure is such that it actually is very difficult to structure home visits in a way on a system level that's financially viable. And so there's a tremendous disincentive to provide care that way, because you make a lot more by not providing care that way. And again, if we restructured how we thought about payment and how we thought about organization, which would be supported by public health, then we would be able to do that. In Costa Rica, they have a system where they have community health workers to go visit everybody, because the reality of it is that you don't need a doctor to teach somebody about diabetes. You know, you don't need a doctor to teach somebody about nutrition. And they're incredibly effective, and those community health workers know when somebody's not doing well and get them a home visit. It's a different way of organizing the system.
Yeah, absolutely. And even to the, you know, it's so focused on billing because there are limited professionals who can bill. You can't even send a nurse in and get reimbursed for a nurse going into a home unless that nurse is part of a home healthcare system that is coming in because a clinician has ordered antibiotics to be given, and then that nurse can go in there, but it's paid through home health. It's not paid through any other way. We've divided it up yet again. So it's like, yeah, if you want that, you got to get home health. If you want to stay at your home, you got to go through hospice services and get it covered through hospice services, you know. And so does it have to be the typical clinicians that can bill in today's insurance thing, where it has to be a physician assistant, a nurse practitioner? Sometimes you don't need a nurse practitioner going into a home. A nurse is fine, you know. So is a community health worker in many situations. Community health worker is just fine to go into somebody's home. So we have this very insurance payment focus system that prevents us from doing the right thing and the best thing and the most affordable thing.
So we have a
So I would
question
like to
for,
say we're at, I'm sorry, Bill, we are at an hour. If the panelists can stay here, I think we have 10 more questions. All right. We got at least 2 thumbs up. Okay, we'll go for it, Bill. And if people need to leave, feel free to go.
yeah. So a question from the chat that I take as a vote of approval for the presentation is, are the panelists open to having the recording on either public or media or television? Good, okay. And another question was for primary care physicians and how that relates to personal religious beliefs, and how does that play out, and does that play out differently in Europe from whatever experience you have?
I can offer that at Sunrise, we have had and have clinical team members that have a wide variety, a diverse background of religious beliefs. What we ask is that none of us, no matter what our religious belief is, project that onto our patients. We meet them where they are. If they are asking us to do something that we don't, if the patient is asking Dr. Wallace to do something that doesn't align with his religious beliefs, we ask him to refer that patient to someone where there is not a conflict, and ask him not to push his religious beliefs onto the patient. However, having said that, you did see I have to provide required services, right? So I have to make sure I have a team that can do those required services. But within that space, we got some room as long as I got some people who can do it, right? So we've had a Catholic deacon on our team. We have people who practice the Muslim religion. So we have a wide diversity. So there's room.
Mm.
Mark, I don't know, is there something you
No,
know?
I think, yeah, I think what's interesting about the conversation around religion or spirituality, religiosity, is that it is in many ways connects individuals to social supports that may not exist, that may be where they get other forms of support from their faith community. It is generally has a positive outcome on health as long as it is one that is voluntary. It is when I choose to go to that and have that source for me, add to how I heal myself, how I deal with trauma and all of that. Where we get to be a little bit different is we attempt in many situations to either regulate for or against something, and then it's not voluntary. If I don't believe what you believe, that's not a source of support for me. That could actually be a further trauma to me. And so I think that's where, when we're delivering healthcare services, especially in a secular world, we have to be cautious, because then we can provide further trauma. And I have had patients that didn't understand where they were going or the influences, and they found, afterwards that they had been traumatized. But I don't want to make it sound as if religiosity itself, when it is your community and you are fully aware of the beliefs, you share them, those are positive outcomes for health.
Yeah, I mean, I think that this is another area of actually public health primary care interaction that's probably worth, since that's one of the topics here, is that I think we need to train our providers to do a good job of assessing a patient's spiritual place. And notice I didn't define that in any way. I mean, because we all come to it differently. I mean, I think,
Yep.
here in Colorado, a lot of people's spiritual place is the outdoors.
Yep.
But helping them to find a way to connect with that is probably one of the most important parts of healing that an individual can have. And I think, I think connecting people to what feeds their soul is essential. I think telling people how to connect is dangerous.
Yes.
And also telling doctors and nurses how to connect is dangerous. So I think we have to be careful.
Another question that we have is, how does this discussion that we've been having relate to climate change, and how do we tie that in?
Earth Day every day. It is my hashtag. I say it all the time. People know I'm coming around behind them at work to watch what they're doing with how many paper towels they pull out when they're drying their hands. I mean, I'm laughing, but it is part of what we talk about a lot at Sunrise, and if you're going to define community health as the broader community, it is absolutely part of what we need to think about. I'll let our public health folks.
Well, I mean, we need to think
more.
about, on the primary care side, we need to be thinking about how do we assess the environmental effects of climate change on individual health. I mean, I think a great example of that in northern Colorado is that the quality of air here sucks real bad. We have some of the worst air particulate statistics in the United States, maybe outside of Southern California. And that affects our respiratory health. And therefore, we need to be addressing that on the individual level, and then B, public health needs to be funded to address that. So on the Board of Health in Larimer County, we're getting a lot of presentations and having a lot of conversation around what is it that can be done to alter some of that environmental harm. So one thing is if you have a gas lawnmower, go get an electric one. I mean, there's simple things like that. But the reality of it is the public health department in Larimer County has a budget of, say, roughly $12 to $14 million, right? UC Health, one hospital, has a budget in the hundreds of millions of dollars, right? You're talking about such different levels of money that we really need to think about how do we direct some of what we're spending onto that prevention side, on downstream prevention. I'm not talking about telling you to take a hypertension medicine. I'm talking about like, how do we structure our environmental response, and that we don't have the money to do that.
And if we're going to address issues of equity in healthcare, the negative environmental impacts of climate change disproportionately affect communities of color, often those who are lower income. If you just think about what neighborhoods look like, if we're going to see temperatures rise and your neighborhood is treeless and is paved over with black asphalt everywhere, the temperatures in your neighborhood, living in your affordable housing with no air conditioning, is going to affect your health differentially than somebody living not very far away, but in a community in which there are a ton of shade trees that are mature, in which the houses have the ability to have circulation or cooling. So those impacts are going to be disproportionate. So we're not going to be able to escape the reality that we are confronted with inequitable impacts from environmental change. And that's going to fall right now. It falls to the healthcare system. You're going to have an asthmatic in one place who can't be controlled because of this impact, and in another neighborhood not far away, not have the same challenges of controlling their respiratory illness.
So maybe if we have time for one more question, wondering how you might want to speak to the strategies that we need to address this misalignment of financial incentives that we have in our system.
I mean, I've been speaking for single payer healthcare for 15 years. I mean, I don't know that it has to be a single payer system. I think that that's the one that has the best roadmap. But the reality of it is that we have to redesign a system to save that 5% of our GDP, so we can spend that 5% of our GDP on public health or on things that will affect the social determinants of health. Because the reality of it is we can spend all the money that we want on chronic disease management, but there is a limit to the success in that and how it's going to affect long-term outcomes and how it's going to affect quality of life. Like, there is a limit to the efficacy of medicine. And until we begin to think about how do we have healthier communities, right? And really think about that both from a policy level, a structure of the way that we live level, what we eat, what we drive, how we educate our families, we're going to fail, because medicine is such a small piece, as I think a couple of those slides showed, of the wellness pie, that even if you make that really super amazing, it's not going to be effective at improving wellness.
Yeah, we're going to have to stop wasting money where it's not effective. We're on course, and we use this example. If you look at historically, the adult population, about 7% of the adult population will have diabetes. Because of what has happened with childhood nutrition, for a whole variety of reasons, what's available in stores, what we feed children in schools, lots of situations. We are now on a path where at least 25% of adults will have diabetes. That is unmanageable. We're going to be in a position in which we can't even do it. I mean, we're going to have to create more of the same system we had that could have prevented the disease if we'd only funded it over here, rather than waiting for 25% of adults to have that. It's going to affect their ability to work. It's going to affect, how well we can have enough meds to, even manage them. And we got to stop. We got to get over on this other side. And it comes through electing people who will create policies that are going to support that.
Good job security, though.
Sadly.
That was very cynical, but I feel pretty cynical,
Well, it is. I mean, it's really challenging just driving back from our event at the UC Health Hospital in Greeley, where we were around these great young medical students. is a story about adolescent obesity that is heart-wrenching. It was absolutely heart-wrenching to listen to it. And we're just sort of throwing our hands up and going, oh, there's nothing we can do about it.
I think that attitude, though, Mark, is something that we really need to think about because, alas, just like guns, healthcare, we aren't, as Bernie said in his talk, we don't have to reinvent the wheel. This is being done all over the world. It's just not being done in this world. So while all of this sounds really daunting, it in fact is being done in reality. It's not a pipe dream.
No.
So thank you.
Yeah, totally agree.
So I think those are the questions that we have, and really hearty thanks to the three of you for for a very wonderful presentation and an inspiring presentation to help us live with the cynicism.
Yes, and I hope that the people who are, I'm sorry, go ahead, Mitzi.
I was just going to say thank you to all of you. You're volunteering, you're putting the energy in, you're bringing your expertise. I commend you because I do think this kind of stuff and what you are doing, the arc of justice is long, but it's right, you know, you're on the right path.
Thank you.
I'll second the thank you, because I think in reality, the future of this is political. And we need to be asking the question of how do we galvanize our population around understanding that prevention really actually isn't what happens in the doctor's office, it's what happens in public health. And how do we actually fund that in a way that we can improve the downstream health of the public? And until we do that, we are destined to fail.
Let's do it.
Well, thank you, everyone. I guess I will do my closing remarks. As you guys saw on the action slide, there's a lot going on to try to get this done. And we really wanted to have this event because it's really important that people look at healthcare holistically, that the purpose of healthcare is to maximize the health of the community. And that's what these three branches are trying to do. But we have to have a paradigm shift that that's the purpose of the system, not free markets and not profit. So there's a lot of things people can be doing, and we will be sending this to people, a follow-up email of the people who are here and that registered. And so certainly if you have any questions, feel free to reach out to me, to Sarah, whatever. We'd love to have your help to make this a reality. Thank you so much.
Thanks much.
Thank you, everybody.
Good night, all. It's past my bedtime.
Well, take
Sweet
care.
dreams.
Sweet dreams. Good night.